discussion with our executive directors about managing care transitions during the pandemic. I appreciate you signing up and participating in the call with us. It's great to have you all here. Just want to take a brief moment to introduce myself. My name is Lisa Relic. My role at Hebrew Senior Life is to work with professionals and community organizations to work with you in terms of bringing information about Hebrew Senior Life and our different communities, doing educational programs, participating in conferences. And I put this call together today just to really wanted to show that we're, what's been happening since the pandemic started at Hebrew Senior Life, and to share with you information about that, and to really let you ask your questions and to hear directly from our directors. So joining me on the call today is Scott Ariel, and Scott is actually having some technical difficulties, so he may be joining just by phone. And Maureen Bannon, who is our Executive Director of our Home and Community-Based Services at Hebrew Senior Life. So if anybody can't hear me or is having trouble, please raise your hand. Otherwise, I'm going to turn it over to Scott. As I said, he's going to be on the audio, but Scott is Executive Director at our Healthcare Center at Hebrew Rehabilitation Center. And Scott's going to start off by talking about what's been happening there since the pandemic, what our response has been, and what the current situation is at Hebrew Rehabilitation Center.
Thank you, Lisa. Good afternoon, everyone. I'm continuing to try and log on, so at least you can see me and hear me. And Lisa and team, can you hear me?
Yes,
we can, Scott.
Okay,
clearly.
Thank you. Thank you. So what's going on? You know, I think this pandemic has been certainly a learning experience almost by the day, certainly by the week, as we adjust in the skilled nursing world to the ongoing changes that come from DPH and CMS. And so I am the Executive Director, as Lisa said, for the Healthcare Center here at Newbridge on the Charles. That includes a 50-bed skilled nursing facility. I'm also the licensed administrator for the 50 skilled nursing beds that are in the Hebrew Rehab Center, Roslindale Center. And because this is a hospital license, this is technically an HIH, or the SNF unit is an HIH. Within an HIH, and that's why you can be one administrator in two locations. It's sometimes confusing in the field, and people will often ask, how do you get to do that? And that's how. And this is, as you most will know on the phone, we are licensed as an LTAC, a long-term acute care hospital, and not a nursing home. And that's also confusing to the community, that we are known to be thought to be a nursing home, when in fact we're actually a hospital with smaller nursing home units. So I want to jump right into COVID. And caught off guard, like I think everyone was, we went into action with creating two COVID units, one in Roslindale, one in Dedham, to isolate and to care for our own. As you know, with COVID coming from the outside, at least that's what happened to us. It came from the outside in. And we responded with trying to protect our patients, protect ourselves, and mitigate immediately the effects of COVID-19, given that we have such a large, frail population in two locations. Large that there are 425 frail elders in Roslindale and 220 here in Dedham. We needed to and did jump into action soon. Those units were full. We had one way in and one way out, and we scrambled to grab the team together for both locations, those who first wanted to, and those that we could train and have that specialized sort of attention on the dedicated COVID units. And for all of us, I'm sure you experienced the same. In this pandemic, we experienced lower staff ratios, and obviously so for lots of single parents who were coming from a place of fear and not wanting to come into a place where potentially they could be exposed and then go home, whether they were caring for a frail elder of their own at home or their children at home. We did experience in the pandemic a lower staff ratio initially, not frighteningly low, but lower. And then, as we all know, this pandemic requires more staff and more timely sort of effects in the day with donning and doffing full PPE. And anyone who has observed, and certainly everyone here on this phone has experienced the time it takes to answer a call light, to respond to a request of a patient, to don your PPE if you're coming onto the floor for the first time, and then doff, and then, oh, by the way, the call light just went on again. So lessons learned were, sort of buddying up, if you will, and checking in with the patient more often while we were in the room about, unanticipated needs you might have. Are you hungry? Are you thirsty? Can I get you anything more right now before I leave the room? Did you hear what I said when you asked me a question? Because it's often hard and difficult to understand what's being communicated when you're in full PPE behind a mask and shield. And if you're hard of hearing and if you're not feeling well, lots of communication was challenging. And so as the demand for those specialized units lessened, we transitioned back to the skilled nursing requirement of a 14-day quarantine. And so every new admission comes to us, to the skilled units, Rosendale and here in Dedham, on a 14-day quarantine, and that means no visitation for those first 14 days. And for those first 14 days, we're offering, as most do too, alternative means of communication via FaceTime and Skype, and it's difficult. And especially now, hospitals are opening up to some visitation, but when you come to a skilled unit, it's our approach on the recommendation from DPH that we maintain our 14-day quarantine. We did maintain just about an 11-day length of stay pre-COVID, and of course that's bumped up to right now about 21 days in Dedham and 25 days in Rosendale. There's slightly different patient populations in both locations, where Rosendale is a little more medicalized and Dedham is very orthopedic. So Dedham, with a shorter length of stay, we weren't able to keep, and nor should we keep, patients for 14 days if it's not medically necessary. And that was in conflict with DPH because they would require a 14-day quarantine. So we went back and forth and still are negotiating with DPH on that. When we have someone not needing a 14-day quarantine, do we need to keep for a 14-day quarantine? And again, it still is in negotiation. They, DPH, were mandated on June 1st by CMS to audit 100% of the skilled nursing facilities in Massachusetts, all of them, all 388 at the time, by June 30th, and they did. We were surveyed 6 times by DPH, and they split the surveys into a federal and a state. And the federal had 28 points, the state had slightly fewer points that they would survey us. And when they surveyed, they were here all day. And so we were surveyed in Dedham on June 16th, in Rosendale on June 19th, in Rosendale again on June 23rd, in Newbridge again on June 25th, in Rosendale again on June 30th, and finally, lastly, on July 14th here at Newbridge. And as anyone and everyone knows, when you're in survey, and when they're surveying for, in this case, our infection control practices, they get to observe anything that they want, and they can find anything that they want. And so far, we have 3 of the reports back that are with no findings, and we will respond as we get what's called a 2567 and make a plan to be sure we are addressing our patient care in the safest way that we possibly can. Where we are go ahead.
Oh, no, go ahead. I was just gonna, go ahead. I didn't know if you were finished with that thought. Go ahead.
Where we are going is, I guess, like so many of us, unknown. It looks like we are spiking in with COVID again in Cambridge and on the Cape and in Quincy, and it looks like it may be heading this way, and we're anticipating that too. And we provided many things to staff to try and keep them as engaged with us and motivated as we could. So in the pandemic, we blocked 60 hotel rooms, and we offered them to our staff to stay in. Anyone who could, anyone who wanted to, could live in the hotel rooms through the initial phases of the pandemic to make it a little easier for commute to and from. Staff appreciated it. We provided free meals on site, all meals for all staff, all shifts. Staff did remarkable things among themselves in coordinating childcare when many were stuck. And so, for example, if I was working 7 to 3 and I have a colleague working 3 to 11, then we would pair up, and I would watch children in the evening, and my colleague would watch my children in the day, and it worked. And so we developed communication and collaboration through the pandemic that I think proved to be successful and will carry us into the next. And we did not experience a significant loss in staff as others did. And we maintained our focus on care transitions throughout the pandemic because we needed to open up the short-term rehab beds to the hospitals who were needing to, send their patients to the next and lesser level. So we never stopped admitting, but we experienced, I think, what the hospitals were experiencing, and that was when the patient was ready to leave our facilities in the skilled nursing, fear in the community was such that we were having great difficulty and continue today, to this day, a bit of difficulty in getting patients to the next level than with our home care, for example, because we can communicate via phone and email, and even with distancing in person, it made it easier to make care transitions, at least within our own system that way. And we relied on our home care and other home care agencies, but we relied on our home care to help us with that way, a speedier, easier, safer transition, care transition.
Lisa, I think you're on mute.
Yeah, did I lose you?
Sorry about that. No, I'm here. I'm sorry. I think I double hit the button. Scott, thank you for sharing all those details about the inner workings of what was going on at Hebrew Rehabilitation Center. I just want to pick up on a couple of things and maybe ask you a couple of questions that I think that there were a couple of questions submitted before the session, and then, people were asking, you talked a little bit about employees and how they partnered up with childcare and what the experience was with employees, which was, I think, probably helpful to this team. The other thing I wanted to see if you could elaborate a little bit on is, people who are working with their clients who may be transitioning to or from our healthcare centers, what words of wisdom or tips would you give them in terms of if they're working with someone, in terms of the expectations? You talked about the 14-day quarantine. Maybe you can talk a little bit about the testing that goes along with the 14-day quarantine.
Sure. The rules from CMS and DPH continue to evolve, if you will. And last week, we were updated last Friday that a skilled nursing facility in Massachusetts can no longer require a COVID test prior to admission. You can request, but not require. So what we've done is, of course, we have every patient who's coming from anywhere going to a private room, but we will test on arrival and quarantine, and staff is in full PPE. We will test again in 14 days, and if the patient is continued to be asymptomatic and negative again, then the visitation restriction is removed, and in skilled nursing facilities, you can visit with outside visitation, and that's what we do. And so if there was a provider of some sort, if there was a geriatric care manager caring for a patient, certainly the quarantine time is the time that we would offer the alternative communication with Skype and FaceTime, and then open right to the visitation in person with outside visitation. It is limited to a half an hour right now, and if family and the geriatric care manager or another friend wanted to visit, then we would recommend to the family that you split the time, split it in half, make it 20 and 10, whatever you want to do is fine with us. But there are half-hour blocks, and it's a bit of a scheduling issue with trying to get everyone in who wants to see someone they love in a timely, easy, and efficient manner. So we schedule, and we hold to that schedule, and we over-communicate about directions and where to go, and so that no one is hopefully lost on this large campus when they arrive, if it's for the first time, and don't lose precious time for visitation that's scheduled.
Great, that's helpful, Scott. I neglected to say at the beginning, if you have questions, there's a lot of people on the call, so I don't know if the best thing is to do it live, but if you want to submit something through the chat, please go ahead and do that. We can have questions at the end as well, but if there's anything relevant to what Scott's just talked about that you want to hear more about, please submit a chat, or if you don't know how to do the chat, or you'd rather raise your hand and speak, that's fine too. Just raise your hand or unmute yourself, and we can do that. And so, Scott, the last thing I'll just clarify with you is, so we are still admitting people both to the short-term rehab units and into our long-term chronic care units at this time, right?
We are, and we never stopped, actually. So we kept that going all along.
Okay, I don't see any hands going up, so I think we'll, thank you, Scott.
Sure.
We're going to switch gears a little bit, and like I said, Maureen Bannon is the executive director of our home and community-based services. So Maureen's team is responsible for home health, private care, hospice, palliative care, and our adult day health programs. And so Maureen's going to talk a little bit about what the experience has been in those service lines, and give you some insight into how they're operating today.
Great, thanks, Lisa, and good afternoon, everyone. It's so nice to see all of you, and to be meeting some of you for the first time, but I also see some trusted colleagues on the phone, and I also see a longtime trusted colleague who is a friend. So welcome, and thanks so much for being with us. And Scott, thanks very much for the introduction as well. As Lisa said, you just heard, that we have several components under our home and community-based services umbrella. In addition to the home health and the hospice, we also have both inpatient and community-based palliative care, the 2 adult day healths, and then we also have an ASAP funded program where we do chore services, homemaker, and personal care. And, we were so thankful during this time to be part of a system. Of course, I have been in communication with many colleagues who have standalone similar organizations, and I think that at times that could be a little bit more difficult, and you'll hear the reasons why for that sprinkled throughout my conversation today. One place to start is really with our home health division. So as COVID began to escalate, we actually began seeing a decline in our census at that time. And the reason for that was because most and eventually all elective surgeries were canceled. So that meant, of course, that we had staff here who were able and more than willing to help. So staff dispersed where they were needed, whether that was into our long-term care facilities, our short-term rehab. They did some work with occupational health. They were also acting as screeners at the entry points to some of our locations, and did some extensive work with our senior living partners as well. So the benefit of all that, too, was that we were part of the distribution of the critical PPE that was so hard to get at that time. And again, being part of a bigger organization, we were fortunate to be able to acquire that sooner rather than later. So any clinician that's on the road does don PPE going into homes. At a minimum, they wear goggles and KN95 masks as well as gloves. And then if they are with a known positive or someone described being symptomatic, they also add the additional PPE of the gown. And then during this time, we learned and became proficient with being able to test people in the home as well. So then we would be fully garbed in PPE when we were doing that too. You know, another reason for a bit of a decline in our census, understandably, was that people were afraid to have us come into the home, the elders themselves, as well as their families, of course. So again, us being able to acquire PPE was certainly anxiety relieving to them when they saw that we had the capability to come in that way. You know, additionally, we do a lot of our work in congregate style living sites. And because of the level of quarantine that had to go on in all of these places, we were often the only outside people that these folks were seeing in the course of a day. So again, to be able to make it as safe as possible and as meaningful as possible for people was really our good fortune. And I have to say, you know, our president and CEO were saying this morning, they sometimes feel like they still have to pinch themselves at their good fortune in terms of the staff, because we had no turnover, and staff were anxious to help one another, as you could hear through Scott's example, and also be so attentive to the seniors and their families. So in one way, it didn't surprise me, and in another way, it was just so incredible still to see. Our hospice had a bit of a different story. Although our census went down, our pipeline was the most robust it's ever been. And that's because we actually were one of the first hospices in the state to begin accepting COVID positive patients. And again, that's because we felt empowered to do so, because we felt confident about our ability to do it safely because of the PPE, as well as the training we had had in donning and doffing and infection control. In particular, we were able to partner, for example, with another housing site in the local market that was not an HSL one, but that sadly was very hard hit by COVID. And we took care of the majority of their COVID patients. And it really brought such a value add to that community, because we really quickly integrated as part of their team, which was such a plus for everybody at that point, is including those residents in the home who maybe didn't need our services, but became to recognize us as a trusted relationship within the building. You know, the reason the census, honestly, obviously didn't maintain itself at that time was because as quickly as we were admitting people, people were passing away relatively quickly as well. So as you can imagine, for the staff, that was tremendously burdensome. We have in place, in particular for our hospice, quarterly rounds with our organization's chief medical psychiatric lead. So we ended up adding in another session or two to make sure the staff was doing okay and felt able to move forward with their work, which they wholeheartedly did. Great example, Scott mentioned that we opened up a couple of COVID units at the time. We did have a hospice patient we were caring for who began developing symptoms, and we were able to test her, get the results back in less than 24 hours. And within the time of receiving the results, 90 minutes later, that person was in one of our COVID transition units. And that person passed away the following morning. However, her family was so relieved because she was in the company of others, because the family had not been able to go see her in her own home because they had been, and many of them lived in New York. and New York was in their own troubles at the time. So again, we as tragic as that was for the family, it was really such a positive outcome. A couple of really interesting opportunities occurred for us with our palliative care service line. As I mentioned, we have both inpatient and community-based palliative care. On the inpatient side, it was our good fortune to have a nurse practitioner join us, specialty in palliative care. However, she joined us on March 3rd, which, as we all know, that's when things really started to take off in the state. And the same was true here at Hebrew Senior Life. And within 3 weeks of being here, she was quickly able to partner with our research institute called our Marcus Institute. And it was a great collaborative effort between research and clinical to mobilize on our long-term care units to quickly determine patients' advanced care planning wishes. And this is something we always investigate when somebody comes on board to live with us, but it's not uncommon for the resident and the family, the patient and the family, to be perhaps historically slow in articulating their thoughts on that because it is such a heavy decision to come to. And it was wonderful to have these palliative care experts be able to guide these conversations at such a crucial time to make sure we understood whether or not people wanted to go to the hospital if they became ill. And we look forward to sharing more of that information with you going forward. Many of you may have heard of Dr. Susan Mitchell. She's really an international guru that is part of our Marcus Institute, who has done a lot on advanced care planning with the elderly. And she was very much a part of this whole process and has already presented some components of it. And we look forward to, we're in the process of writing up a paper right now about what we found COVID compared to pre-COVID, and I know there'll be presentations about this as well. So again, we look forward to sharing that with you. On the community-based side, in terms of our palliative care programming, we really at that point leveraged the skill that we had of our palliative NP and the queued up position we already had of a palliative social worker who joined us to really reach out to people telephonically. We also have the good fortune of having a part-time palliative care chaplain. And so a lot of activity occurred over the phone that really was described as very helpful both for the families as well as the residents and families helping community dwellers and congregate housing residents to, again, get through that time in a meaningful way. So in addition to that telephonic work that we were doing, we also had already had a robust telehealth program in our home health division. And I'm sure many of us are more informed about what telehealth is at this time because so many of our physicians are doing that with each of us. What was different pre-COVID for us was our telehealth programming was more about data gathering and being a teaching tool. So specifically, we would do symptom measurement through the usual vital sign determination of heart rate, pulse, temperature, oxygen levels, people weighing themselves. We can gather all that detail in the home by putting equipment in the home. And then we can also do some teaching through a Q&A process. And then all that information is transmitted over to us. And if we find that something is an aberration or deviating from normal, we're able to make a phone call and make an extra visit if we determine that's necessary. Just prior to COVID taking off, we had just acquired video capability additions for this equipment. So in the height of COVID, it wasn't appropriate to be able to implement that process, but we have started doing that now. And in addition, we've extended our reach to the people who are really most at risk and have the likelihood of most benefiting from this service. And the group, I think, that highlights the era we're in right now most is are individuals who have had joint replacement surgery, whether it's a total knee or a total hip. And the reason for that, I think, is compared to our baseline age of the people we take care of, we tend to be 10 to 12 years older than like organizations, state, national. So our average age is about 90 to 92 of the people we care for. Not unusual in our hospice for us to always have a few people over 100. But our joint repair population can be, on average, in their late 70s. So still quite young, still very active. These are people who have been runners maybe all their lives, and now they want to keep doing that. And they have been able to embrace the technology with the new telehealth and also give us feedback about our teaching tools that we're using there and how they feel like they acquire the education really quickly and are hungry for us to shift the education questions maybe more rapidly. So that's what we're in the process of doing now. So this has been a really good period for us to be able to try to broaden and gain greater expertise in that technology too. We're also partnering with our housing site group on how we can perhaps offer aid support to those at risk in congregate housing who might be struggling with how to interface with their physicians through telehealth. We're trying to learn of a way that perhaps, again, our aides can be helpful in that way somehow. So more to come on that. Our personal assistance division was really a shining star as well during COVID. Interestingly, this particular population had very significant growth during this time, and I see the reason. I see the reasons for that being a couple. One is we had just certified several of our active aides to become what are called supportive home care aides. And this means that they're able to take care of a more highly complex level of patient that the ASAP may need them to be able to take care of. And that proved to be true. We were able to pick up some more cases from our ASAP referral partners and service them better. So that was wonderful. Additionally, again, we recognize that not only our own housing partner, but some other housing partners, because of the quarantine, really needed some different help with being able to care for their patients. And we were able to offer what we call a short shift private pay offering to those in congregate housing. And specifically, it allowed us to put a worker into the building and offer as little as 15 minutes of supportive care, which made it a lot more affordable for the residents and or their families. And we might do something like help somebody put on TED stockings or remind them to take their medications or something like that. Again, it needs to be in a congregate style living situation because that way we can put the aid in place. In many instances, the senior living facilities found it during the peak of COVID worth their while to share some of the cost on that. And then in many cases, often the family is paying for this for their loved one. So again, I can't say enough about this group in particular because this is a group of workers that is primarily traveling by T. Most of them don't have cars, and really they never missed a beat. I did not have one employee say to me, I can't do this, which would be understandable because so many people have children and we were all scared. It was so unknown and it continues to be, but really it was such a moment of everybody leaning in. And I think, again, that speaks really highly of the cultural values here of such collaborative efforts. I will speak, I know there was one question about our adult day health programming, which I really appreciate, and I can speak to that as well now. For folks who may not know, again, we have 2 adult day health programs. One is located at our Roslindale Chronic Care Hospital site, and one is located at our collegial site in Brighton with 2 Life. And I'll start with our 2 Life location. we just reopened our adult day health fair yesterday, and we had a wonderful first day. As you can imagine, things look very different now. We need to maintain, of course, proper social distancing. The participants need to wear masks. The staff, of course, wear PPE, including masks. And what we can offer for a number of attendees is significantly less than it has been. We need to, again, maintain social distancing. And at all these programs, people do receive meals and snacks. So we're being particularly cautious and proceeding very slowly as we ramp up to the full number that we are able to move forward with. The reason that we were able to start with 2 Life is because the adult day health fair is located in a bubble, which we've all become familiar with. And that is because all the attendees at that adult day health live within 2 Life. So we know that they're accustomed to one another as a community, and there's no transportation risk involved for anybody getting there other than movement through the hallways, and again, social distancing and good practice around that occurs. Our Roslindale location is not open at this time. We're being very cautious about how we think about moving that forward. Anybody attending that location does need to come from the outside and travel on transportation that can be as varied as coming in a family member's car, coming by a chair car, coming by the ride. And so there are really all kinds of potential risks with that. And then they're coming into a site where other elders who are already at risk are living as well and putting themselves at risk by coming into that site. So as you can imagine, there's still lots we're considering for that particular site. And then I'll finish before I pause with a similar place that Scott did as well, and that was around our employee engagement. You know, I have heard so much from our staff that floated during this time that it was their great honor to have been able to do so. And it was happenstance that that was an incredible employee engagement opportunity for our staff. They really were so appreciative of being able to help the elders in any way they could, and their colleagues as well, which was really super powerful for them. Our Chief Nursing Officer, Tammy Ritalik, recently invited all staff to do a project called 50 Words, which asked staff to consider in 50 words what the experience was like for them. And again, it was really a tearjerker, what some people had to say. And although we thought we knew what was occurring for staff on a daily basis, what was going through their mind was, again, really, really powerful to hear. We also, of course, have to engage our employees different in community-based services because they're out on the road. So as Scott mentioned, we quickly organized a command center here, started March 3rd. We were meeting initially 3 times a week, and then, adjusted that as necessary. And so our road employees were always kept immediately informed about what was going on within those command centers. And we would receive updates about our status of our patients, our status of our employees, how we were managing to go forward, IT support, also a huge undertaking, as you can imagine, because some people, like many of you, were working remotely, and our IT partners were incredibly rapid in their response of getting everybody up and running on Zoom, and how critically important that was for us to be able to continue to do intakes for those in need. So I'll pause myself there and Lisa, hand it back to you and see what you'd like to do next.
Thanks, Maureen. That was great. One thing I did want to mention, Maureen, and I think I've said this to you, but one of the things that I heard from my colleagues or counterparts out in the community about the Adult Day Health Program is how helpful it was that they didn't completely close, even though they were physically closed. Susie Cadis, the director of the programs, was able to do a session once a day with the participants and once a day with the caregivers, so that they did have virtual support during the time. And I think that was really unique from what I've heard from others. So I just wanted to mention that, and I think that people really appreciated that during this time.
Yeah, I agree, Lisa. Thanks for bringing that up. And it was very important for the participants. We actually had a lot of attendance, and we decided from that to start a caregiver support group, and it was very well attended, which was wonderful as well.
Right. Yeah, no, and I actually will mention, we have I think it's about 4:13. There was a couple questions that came in that I want to pass over. One is to Scott. But one of the things that I wanted to mention before doing that was that we do have the Center for Memory Health, which is an outpatient clinic at our Roslindale site, which opened almost 2 years ago now, that treats patients on an outpatient basis. And there's a family care support program for people with dementia, as well as a program for people with dementia. We do diagnosis there. And there's just a lot of resources available, and they're reopened now on a part-time basis as well. So just want to mention that if anybody needs that resource. And please, everyone has my email now. So if we haven't met, I'd love to hear from you. If you have questions, if you want to be connected to anybody within Hebrew Senior Life, please reach out to me, and I would like to facilitate that. One of the questions that came in.
Lisa,
yes.
Lisa, if I may also just continuing on the Center for Memory Health, they are also doing some work with telehealth as well. So again, your recommendation, give them a call, because they're really trying to help people out as much as possible.
Yeah, and if you haven't seen our website in the last 6 to 9 months, I think it was last September, we gave it a full overhaul, and it's really great. There's a lot of information, and it's organized by location now as well as by service. So we really tried to redo the site and make it so that it was the information people were looking for, how they would think about it, as opposed to how we were organized internally. So I would invite you to visit HebrewSeniorLife.org. If you have questions, check out our new site. I think there's a lot of resources, a lot of information about COVID. One of the things that you may know is that Hebrew Senior Life was asked by the Mass Senior Care Organization to help with putting resources together for infection control to help other skilled nursing facilities. So that's something that our Marcus Institute and our healthcare team has been involved in. So as we were going through this, we were also sharing resources on our website about protocols that we were doing to try to help others in the industry. As we were figuring it out, we wanted to share what we were learning. So I invite you to take a look at that site as well. So Scott, a question that came in is for inpatient. Are patients still receiving OT, PT in their room at the Hebrew Rehabilitation Center currently?
Both, in their rooms and then in the gym. So we're being very cautious, and one person in the gym at the time, but as we get closer to discharge date, of course we want to maximize the functional independence. So in the gym, that's where they would use the stairs and get more of the, more aggressive rehab needed to return home safely and stay home.
Okay, great. So I hope that answers the question that came through. And I encourage anyone, if you have any other questions that you either want to submit to the chat, or if I see any hands go up, I'm happy to have you ask your question. Again, I want to thank everyone for participating. One of the things I've been so impressed with, I've been at the organization will be 2 years in November, but I've had the opportunity to hear our CEO, Lou Wolf, speak a couple of times since COVID started. And one of the things that was really important to him, and it comes through in the organization, is being transparent and telling people what's happening, what's going on, and sharing that information. And the amount of communication, either virtually, written communication, that's gone on between our patients, our clinical staff, and our families has been incredible. And really just being forthcoming with information. And as I watch these different events, it made me realize that we should do the same thing for our professional partners that we're working with on a regular basis. We rely on you, you rely on us, and it's very important for us to be forthcoming with information, make sure you have the resources that you need to answer the questions your patients have and you have to help your patients. So please reach out to me if I can help you, if you have questions, and we really want to be there for you. And thank you for all your support during this time. I haven't seen any other questions come in. So it sounds like we're going to wrap up early by a couple of minutes, but thanks again, everyone. I will send out the recording to you all. So if you want to refer back to something, and I hope to do this again. And so thank you.
Thank you, everyone.